Thank you so much. And a big welcome to everyone. I see we have a good number of folks on the line. So we're just really excited to kick off the week. This is HPV Prevention Week, and we're excited to have a great week of talks during this Us versus HPV webinar series. I'm Dr. Elizabeth Garner. I'll be the moderator for today. And I'm sure you already received this information, but just as a reminder, who's hosting this is the American Medical Women's Association and the Global Initiative Against HPV and Cervical Cancer, along with Indiana University. So we've all partnered up together to recognize January as Cervical Cancer Awareness Month. We're hosting the webinar to really spread awareness about not only cervical cancer, of course, but the various diseases that are caused by the human papillomavirus, or HPV. And as you'll learn from today, there's quite a few diseases that are caused by HPV that go well beyond cervical cancer. And we're going to talk today about all of the ways, the excellent and effective tools that we have to prevent cervical cancer and all the other HPV-related diseases. So our goal really of the whole webinar series is to raise knowledge, to encourage and empower the members of the audience, and really to ask you to join us in this campaign of increasing knowledge about and awareness about HPV and about the approaches towards preventing HPV disease. There are a number of ways to access this event. There's a live stream, you can dial in, there's also video replay, and these webinars are all going to be recorded and they're free, so you can actually come back and listen to various pieces of stuff if you want to remind yourself of what you heard today. There's also information about the series at Us versus HPV. We're on Facebook, we're on Instagram, and we have a Twitter handle, which is hashtag Us vs HPV for Us versus HPV. All right, so I'd just like to say a big thank you to all of our supporters. Quite a number of organizations have come in to partner with us and support this effort. Okay, so today's topic is the HPV vaccine and an update on HPV disease, sort of an intro on HPV disease, and then we're going to focus in on the vaccine itself, the development of the vaccine, and then what's happening today in the US around use of the vaccine. We have three speakers. We're each going to speak for about 15 minutes, and then you'll be able to ask questions, and we'll do a live Q&A. So you can submit your questions at any time during this webinar through the Q&A icon that you should see at the bottom of your screen. And as I said, we'll do our best to answer your questions live during this session. There are some handouts also that were made available, and those are in the chat box icon that you also should be able to see at the bottom of your screen. And you'll get a link to these handouts after today's webinar. All right, so we'll move right on into the talks. I'm actually the first speaker for today, and I'll be talking about an update on HPV-associated disease burden, and I'm going to give you an introduction into HPV vaccines. As I said, I'm Dr. Elizabeth Garner. I'm currently the Chief Medical Officer at Agile Therapeutics, which is a women's health company. So I'm mainly on the industry side now. I am a GYN oncologist by background. I specialized in GYN cancers and spent a great deal of my time actually treating HPV-related disease, not just cervical cancer, but the other cancers that are caused by HPV, as well as precancerous disease that you'll hear more about today. I used to work for Merck Research Labs, actually on the Gardasil and the Gardasil 9 vaccines. So just a brief outline of what I'm going to talk about today. I'm going to give you some introduction just to HPV itself, how it was discovered that HPV was related to cancer, recognizing that actually cervical cancer and a number of other cancers are actually caused by an infection. And then we'll discuss the various HPV-related cancers. And as I said, I'll give you an introduction to the vaccine, or I should say the vaccines that are available. So viruses, as you may know, can come in various forms. They are basically either DNA viruses or what are called RNA viruses. In terms of HPV, it is a DNA virus, and it's transmitted mainly through skin-to-skin contact, and I should say intimate skin-to-skin contact. So just holding hands with someone, for example, is not a way that HPV is transmitted. It really has to be more intimate contact generally, and most of the time through some form of sexual contact. Infection with HPV is the most common sexually transmitted infection, and I think that's a really important point because I think it often gets forgotten when people talk about sexually transmitted infections. We tend to think more of things like gonorrhea and chlamydia or herpes, and oftentimes HPV is sort of not on that list. And a lot of that is that really until it actually causes disease, there really are no symptoms of HPV, right? So people don't necessarily know that something is wrong or that they have an infection in the way that they do, say, if they have gonorrhea, where they have a particular discharge or a symptom. But infection with HPV is indeed the most common sexually transmitted infection. Amazingly enough, about 1 in 4 individuals in the United States are infected, and over their lifetimes, people who are sexually active, about 80% of people will get an HPV infection at some point. The really important point, though, about HPV is that as opposed to many other viruses that never go away, that don't clear, for instance, herpes. If you get herpes, you basically have herpes, and you will always have herpes, for the remainder of that individual's life. HPV infections, on the other hand, actually clear and go away very, very frequently. In fact, although that number of 80% might sound alarming, in fact, most of those people will clear or get rid of their own HPV infections just with their own immune systems. It's that small percent of people who don't manage to clear the infections, whose immune systems, for whatever reason, and those reasons are not generally well known. There are some cases where people are clearly more prone to not being able to clear. People whose immune systems, say transplant patients, people with HIV whose immune systems don't work, those people we know are at higher risk. But for others, sometimes it's not known why their immune system might not have cleared the infection. In those instances, persistence of HPV infection, meaning HPV infection lasting over many, many years, can ultimately lead to precancerous changes and ultimately cancer of those cells that are infected. So it took a while, many, many years before it was actually recognized that cervical cancer, in fact, was a sexually transmitted disease. And it was really over time, as people studied the epidemiology and risk factors, who was getting cervical cancer, that it started to be recognized that the disease was common in women who were what we called highly sexually active. It was very uncommon to see cervical cancer in nuns who were not sexually active. And people started to think, maybe there's something going on here. Could this be a sexually transmitted disease, in fact? And at one time, it was thought that maybe herpes was the cause of cervical cancer. There were other diseases or infections, I should say, that were thought to perhaps be related. But ultimately, after a lot of amazing scientific work, it was figured out that, in fact, HPV appears to be the cause of cervical cancer. And the way that was essentially figured out was that essentially it was found that in the actual cancers themselves, HPV DNA could be detected. And ultimately, it was realized that close to 100% of cervical cancers do have HPV in the cancer. So after that, it was really then found that actually the mechanism, how the HPV virus was causing disease, ultimately that sort of pathway towards what we call cellular transformation was figured out through work in the laboratory setting. So I just want to show you this picture here. It's kind of an image of kind of how the HPV infection causes what we call changes in the epithelium. The epithelium is just the skin, the line, your skin. We have epithelium all over our bodies. We have skin everywhere. So if you think about it, actually, the vagina, the cervix, the vulva, those areas are all covered by epithelium. So people often don't necessarily realize, wait a minute, so I have skin, the vagina is covered with skin, the cervix is covered with skin. So it's all what we call epithelium, and there are various types of epithelium. The epithelium on the cervix and the vulva, the vagina, and for males, the penile area, the oropharynx, the oral area of the mouth. All these areas have what we call squamous epithelium. Squamous epithelium is particularly susceptible to not only infection, but changes due to HPV. So on the leftmost aspect of this picture, you can see those cells are sort of depicted to be just normal epithelial cells, nothing wrong with them at that point. And then the little purple things are the infectious viral particles that somehow get in through perhaps a very microscopic break in the skin that one might not even know they have. Then HPV infection, as I was describing, can set in. At times, HPV infection will just last just a long enough time to cause some changes in the skin, but not precancerous changes. And so we think of that as sort of changes that are just related basically to infection. And that is called CIN, or cervical intraepithelial neoplasia. It's called CIN1. And that is not thought to be a precursor to cancer. And in fact, similar to the way that people will often clear the HPV infection, they will also often clear a CIN1 lesion. But you can see those, doctors can see them when they, or nurses or whoever's doing an examination through something called a colposcopy, can see those changes through a microscope. As I mentioned, there's persistence of HPV infection though, and if it persists long enough, it can lead to actually integration, so where the viral DNA, the DNA itself actually gets essentially into the DNA of the cells by doing something we call integration, and then it can lead to actual changes in the skin, which ultimately over many, many years can lead to actual cervical cancer. And it's believed that the same exact process happens not just in the cervix, but in all of the other diseases that are also caused by HPV, which I'll be describing in a second. So we like to think about this as cervical cancer is kind of the tip of the iceberg in a way. For many, many years, really cervical cancer was thought to be the HPV-related cancer. And even now in this country, sadly, with all the work that's done around detecting these precancerous changes that I described that can be detected, like I said, through these pap smears and colposcopies, we still get almost 11,000 cases of cervical cancer each year in the US. Cervical cancer is still the only type of cancer for which there is a recommended screening test, the pap smear or HPV testing. And these cervical precancers, though, even though they're not cancerous, we can often treat them if they're discovered through pap testing and colposcopy. They can be treated and prevent the actual cervical cancer from developing. So you can see there's that number over on the right bottom part of your slide, 300,000 of these precancerous changes that are detected every year. And very few actually ultimately end up as cancers. And generally speaking, the people who get cervical cancer, in the United States at least, are people who have not been screened by pap smears. I've been mentioning all along that HPV causes a number of other diseases. It's what we call a very potent, powerful carcinogen, a carcinogen meaning something that causes cancer. And because of that, it's a significant cause of mortality. And as you can see in this diagram, there's right in the middle there, cervical cancer, which I've been talking about, but we also see HPV-related vulvar and vaginal cancer, penile cancer, anal cancer, and then of course what we call CIN1, the low-grade dysplasia. And of course, I've not talked about really at all genital warts today, but of course HPV causes genital warts as well. And then higher up on the slide, you see oropharyngeal cancer or tonsillar cancer, and this is one of the cancers that is has been emerging over the last several years, almost as an epidemic of HPV-related disease that's becoming much more prevalent in the United States. So now you see where I've put together, actually I have not put together, Melinda put these together at the CDC, one of our other speakers. These are cancers related to HPV, the numbers for other cancers. I just talked to you about the 11,000 cervix cancer cases, but as you can see here, there's penile cancer, 800 cases a year, vulvar and vaginal cancers as well, anal cancers, almost 6,000, and then oropharyngeal, as I said, that's the number that's really been going up over the last several years, almost 13,000 cases. We don't, unfortunately, have screening tests for these various cancers, so they're often not detected until they actually cause a real problem, as opposed to cervical cancer, where most of the time, cervical cancer, if a person is getting their pap smears and or their HPV testing, they will be detected before they become cancerous. However, we do now, of course, have HPV vaccines, which have been around now for over a decade now. And because these cancers are 90+% caused by a certain types of HPV, which I'll talk about in a second, over 90% of HPV cancers can be prevented through HPV vaccination. So that's incredible. I mean, is there any other cancer that anyone can think of that has something that's so powerful that 90% of those cancers can be prevented through a vaccine? Truly, truly groundbreaking. And what you'll hear about later today is, or on this talk is sort of how through this webinar we're hoping to really raise awareness about vaccination and get the rates of vaccination up. Just very, very briefly here, my time is almost up. I talked about the fact that HPV is the most common sexually transmitted infection. One thing that's very important to understand is there's over 100 types of HPV that are out there, all based on their specific DNA profile. About 30 to 40 of those types can cause tend to infect the anogenital areas, and then about 50 to 20 of them are cancer causing. And about 87% of cervical cancer, so close to 90% of cervical cancer, are caused by types 16 and 18, and then 31, 33, 45, 52, and 58. But the vast majority of all HPV cancers are caused by types 16 and 18. And that is the reason that the HPV vaccines were developed against those two types. And then type 6 and 11 are responsible for the vast majority of genital warts. As you can see here on the next slide, cervical cancer cases, if you look around the world, the green bar there is types of cervical cancers that are caused by type 16. The orange is type 18, so you can see that the vast majority of cervical cancers are caused by those two types, and then the remainder by the other types that I mentioned, 45, etc. Similarly, this shows kind of the distribution of just HPV prevalence, and essentially the main message of this slide is really, again, way over on the right, you can see the circle 16 and 18, again, by far the majority of infections around the world, and therefore the majority of cancers also caused by those types. As I've said, 11, 16, and 18 cause most of HPV disease, 16 and 18 being pretty much responsible for the vast majority of all cervical cancers, vulvar, vaginal, all the cancers that I just mentioned to you. And then similarly, of course, 6 and 11. In the United States, basically the purpose of this table is to show you down on the left all the different types of cancers, cervix, vagina, vulva, etc. The number of cancers in the second column that are caused, as I said, we talked about the 11,000 cervical cancer cases. And then you can see going down the list the percentage that are caused by any HPV type. Again, the same message really being driven home, that close to 90%, at least in women, of HPV-related cancers are caused by 16 and 18, and then the other types that I mentioned. Similar slide here in showing it in a figure form, where again you've got the gray bars here going across along the bottom of all the different types of cancers. In females over to the left here, and in males, you can see the gray is 16 and 18, and then the black is the 5 additional types. Again, pretty much all disease caused by 16 and 18, and then additional several types. There are some differences in the United States by race and ethnicity around the distribution of disease, although typically whites, blacks, and tend to have similar rates, and then slightly less prevalent in other races and ethnicities. And you see a similar distribution between Hispanic and non-Hispanic individuals in the United States. All right, and then lastly, I will spend 1 minute here just talking about HPV vaccines. What's neat about HPV is that it has these virus-like particles that you can make in a lab that actually look just like the HPV virus itself, but have no DNA in them. And these virus-like particles are actually not infectious, which is a great thing for developing a vaccine, because you can actually administer that virus-like particle and cause an immune response that is very what we call type-specific. These antibodies that the human makes then after getting the vaccine can prevent HPV infection. So this is a very, very, very high-level explanation of basically, once people realized that there were type-specific immune responses that we have as humans to these virus-like particles, it was recognized that this could be a very powerful way of preventing HPV infection. And what's amazing about these antibodies is that they are actually what we call neutralizing, which means they really destroy the HPV virus. And that because of that, these vaccines are highly, highly effective. The way that the HPV vaccines in the United States were approved was basically by what we call the basis of licensure, which is basically an agreement with the FDA as to what they need to see in order to approve a vaccine. In the case of cervical cancer, it takes many, many years for cancers to develop. So what FDA agreed to was, well, if the vaccines could be demonstrated in clinical trials to prevent the precancers, right, those precancerous changes that I described to you that happen before cancer, if that could be demonstrated through clinical trials, then the vaccines could be approved. And indeed, that is what was done for the Cervarix vaccine that was, and Gardasil, which were both originally approved in 2006. So the current vaccines that we have available in the United States now are Cervarix. Gardasil now, once it was recognized that although the vast majority of cervical cancers are caused by 16 and 18, those 5 additional types could be put in the vaccine as well and lead to even greater protection against the various cancers and precancers. So Cervarix is a vaccine that has types 16 and 18, whereas Gardasil 9 has 9 types, 7 of them being cancer-causing, and then 6 and 11 which prevent genital warts. Gardasil 9 has been approved for slightly older people as well because of some of the continuing studies that were done. So the ages currently are 9 to 25 for Cervarix and 9 to 45 for Gardasil. I already talked about the types of HPV that they cover. The schedules are pretty similar for how you administer the vaccines over 3 doses through the intramuscular route. So I think the bottom line here is we have very, very effective HPV vaccines that can prevent well over 90% of HPV-related disease in the United States and around the world. So I'm going to stop here and let Teresa take over. The next speaker is Teresa Rohr-Kirchgraber. She's at Indiana University. So she's a professor of clinical medicine and pediatrics, and she's also the executive director of the IU National Center of Excellence in Women's Health. And she's going to take what I've described to you about HPV and the vaccines and talk about what we can do around talking to patients and families to address some of the limitations in vaccine use that currently exist in the US today.
Well, thank you so much, Dana. That was fabulous. Now, with everything that you said, this should be a no-brainer. We should have vaccination rates reaching 100% across the country. But unfortunately, our vaccination rates are only about 50%. 50% of those that were eligible have actually gotten their vaccine. So we need to work a little bit harder on that. Now, what I'm going to be talking about is I really want to encourage everybody to think very carefully about this, not only the physicians and other non-physician providers, but family and patients and kids. So there is definitely a group that are not going to vaccinate at all, no matter what you say, no matter how you bring it up to them, no matter what kind of scientific information you give them. They're not going to vaccinate. They're never going to vaccinate. So what we really need to be focusing on those that are hesitant or not quite sure, or what we call like late selective people. We also have a fairly larger group, luckily, that will vaccinate without any question. This is what they're given. This is what they're going to do. They're not even going to question about it. For those, we want to make sure that the physicians and other providers are always bringing it up and being on top of things for them. But let's talk a little bit about what we call the late selective. That's the patient who, when I bring up the possibility of the vaccine, they're, well, I'm not so sure about it. It seems so new. I want to wait a little bit longer. Those are the people that we need to kind of work on and mention, what is it that you're not comfortable with? Did you know that this vaccine has been going on since 2006? How much more time do you need? Especially kind of discussing with them that we need to get this in early in your child's development. We don't want to be waiting around. So let me talk to you about specifically what is it that you're hesitant about. Also be kind of conscientious about where they're getting their information. Now, because so many patients and families will go and look up things online, But if they're getting their information from non-reputable sources, then the information that they're going to bring and the questions that they're going to have for us are going to be, perhaps a little bit different. For those that are kind of cautious acceptors, we want to really encourage them by the use of personal stories, by the use of examples. I frequently use my own children as examples. I'm a internist and adolescent medicine physician, and my 3 children all got the vaccine. I have 2 boys and a girl, and I think it definitely helps when your physician or non-physician provider is also very enthusiastic about immunizations and brings up their own stories and their own ability to do this. So the other is to kind of think too about where is your staff and how did they understand it. We had one practice in which the physician was very enthusiastic about the immunization practices and didn't realize that the MA who was actually giving the vaccines was not, and would kind of go in afterwards and sort of talk the patients and the parents out of getting the vaccine. And he couldn't understand what was going on until he actually found that out. So it's so important that not just the physicians agree and encourage, but also the rest of the staff and understand why they're reluctant. Now, this study was done looking specifically at those parents who did not vaccinate their children and trying to kind of get a better understanding of where they were coming from. So in this study, we looked at mothers of 14 to 17-year-old girls. So this was a few years ago, and asked, what were your reasons for not vaccinating? It was interesting that the side effects were probably the biggest thing, and most of it was because for a lot of the parents, they never had this vaccine. It wasn't available when they were growing up, so they were concerned that there might be some other kind of side effect. But very remarkable to me was that almost at the same level, it was because the doctor hadn't recommended it. So we need to work a little bit even harder on getting the physicians to be very proactive about this. Now, a little bit even worse, I guess, was when they actually did the same study looking for boys. Now, we have had recommendations for boys to get this vaccine from the very early stages. We know that, for example, boys may not have any symptoms at all, but they could very well be a carrier. Recognizing, I think now that 40 to 50-year-old men are developing head and neck carcinomas, oropharyngeal carcinomas, specifically related to HPV, will, I think, cause a huge impact on getting more parents to vaccinate their children. So in this study, when we looked at it for boys, the most interesting, the top reason why these kids weren't getting vaccinated was because the doctor hadn't recommended it. So yes, we have some work to do. Now, why? Why for physicians and other non-physician providers are they not recommending? It's not that they're not so much recommending, but if you think about this, a lot of times these vaccines are given in a pediatrician's office. There's the concern perhaps that the cost of the vaccine, if you're not giving it frequently, is it always going to be reimbursed, which now we know there has not been a problem at all with reimbursement these days. And they just didn't seem to know enough about it when we first started really pushing it 100%. Especially when it came to having the guys get vaccinated. I think as the information has gone out there, it's been much more acceptable, and we're getting more, the rates increasing, especially when we really kind of push that the vaccine is necessary, and we try to do it from the patient's perspective. When we have recommendations, what we want is for the patient to come in and say, I want my vaccine. I don't want to get head and neck cancer. I don't want to get cervical cancer. Come on, doc, give it to me. And that takes away a lot of the discussion. Multiple studies have kind of shown that when it's the kids and the parents in the room together and they're interested in doing it, they want to get it done, it's going to happen. I think as a physician, initially some of our reluctance was that we didn't want to have a big old discussion about this. We kind of just would like to get it done and get it over with without having to have a big talk. So we need to make it routine. We need to make it an absolute. These are the vaccines that are recommended at your age group, and this is what we're going to be doing today. Do you have any questions? Let's not separate out HPV from the other vaccines. They're all incredibly important. The initial concerns that came out that HPV was just because of sex, I heard from a lot of parents, well, my child's not sexually active. Let's get out of that thought. HPV, while it is very much related to sexual activity, it needs to be given long before sexual activity occurs. So we're not waiting for when they become sexually active. And this is by no means an okay for you to have sex. And the studies have clearly shown that. So our recommendation is that as a physician, as a provider, we recommend, here's the vaccines that you need for this visit. We include the tetanus vaccine, the meningitis vaccine. HPV is just another one. So, and we also recognize that, if we can get these done before you're 15, you only get 2 shots. That's usually a pretty good incentive for most of my patients. 2 instead of 3, they're more than willing to do that. So our recommendation is we need, as physicians and providers, to be very proactive about making sure our patients get the vaccine, even though we may not necessarily see the complications. These vaccines are given during a kid's young age, between the ages of starting at around 9-ish or so. And the diseases that can occur, the cervical cancer, the oral pharyngeal cancers, et cetera, usually occur later on in life, and the pediatrician may not be the one that is seeing that. So perhaps that's part of the reason why it wasn't as the numbers weren't quite so high for vaccination rates as for others. But we need to increase our rates. We need to be able to prevent this disease. We know that by every dollar that we spend on vaccines, we actually save our institutions $3. So there's no question that this is a vaccine that is usable, easy to give, and has a huge impact on society as a whole. So as a physician, I say, it's recommended that you get these 3 vaccines on this visit. Here they are. Any questions? Okay, let's go. And I hope that we all incorporate that into our practice on a regular basis. Even in my general medicine practice now, with the recommendation that HPV vaccine can be given for women up until the age of 46, I have absolutely been giving it in adults and have had a pretty good acceptance rate. So now I'm going to move on. And Dr. Wharton?
Hello, thank you. There's going to be some, I'm going to be re-emphasizing some of the points that were just made about communication with families about HPV vaccine as I talk about how we can do better with improving HPV vaccine coverage. Do I have slide control? There we go. So first I want to just provide a little bit of information about where we are with HPV vaccine coverage, which is really not. The first HPV vaccine was recommended for use in. Can we go back to the slide? The first HPV vaccine was licensed back in 2006. And at that point, there were 2 other vaccines that were also recommended for routine use in young people. The tetanus, diphtheria, and acellular pertussis vaccine, which is the red line at the top of the graph. The meningococcal conjugate vaccine, which is the blue line that's lower. And then HPV vaccine for girls. Now, we are only starting to show coverage on this graph in 2011 when the vaccine was routinely recommended for both boys and girls. And what you can see is that coverage with at least 1 dose of vaccine in the orange line is much lower than it is for these other 2 vaccines. And given that other recommended vaccines were being given at 11 to 12, it's not that kids weren't being seen by a vaccine provider. They just weren't getting all the recommended vaccines. We could understand it that there might be issues with completing the series with the 2nd and 3rd dose that was then recommended when we see coverage with the full series with at least 3 doses in the yellow line below. or with the full series now, which is based on age, which we call HPV Up to Date. But there's no reason why kids shouldn't have gotten the first dose at the same time they got the Tdap and the meningococcal conjugate vaccine. So it's clear that there was a disconnect between other recommended vaccines and receipt of the HPV vaccine. And that's really the problem we're trying to address, is how to get immunization providers, parents, and our health systems to work together to get all of our kids protected the way they should be from these preventable HPV cancers, including cervical cancer. So why is HPV vaccine coverage so low? Again, I'm going to be reiterating some points that were already made. This is from a study done by Rebecca Perkins and colleagues a few years ago that reflects our understanding of things earlier on in the immunization program, but I think it's still relevant in terms of where we are now. So from the perspective of parents, they feel that they weren't offered vaccination, or the discussion they had with the provider led them to perceive that the vaccine was optional or not necessary at that time. And they may even report that their providers discouraged vaccination, and they don't really understand why they're being asked to vaccinate their child at 11 to 12, which seems very young to them. And even providers acknowledge that they don't necessarily recommend it strongly at age 11. They're reluctant to give multiple shots at a visit. They acknowledged back in this survey that they sometimes make recommendations based on a risk assessment at what age they predict an individual child may become sexually active, which is not something that anybody actually knows how to do. That they have limited experience with HPV, underestimate the risk, and that they see it as a difficult conversation that they've got some reluctance to have. So it's clear there's some knowledge and attitude issues that have been a challenge for both parents and providers in terms of getting HPV vaccine given at the recommended age of 11 to 12. In our national immunization survey, which is where the coverage data came from that I showed you a couple of minutes ago, we also asked parents of unvaccinated kids why the child isn't vaccinated. And here in this slide, we show those data from our 2017 survey for both boys and girls. And what we see is that there are parents who've got concerns about safety, but if you look at all the other things together, there's many more parents who report that the vaccine isn't needed or necessary, it's not recommended, they don't really know about it, or their child's not sexually active. And all of those things should be addressable by a strong provider recommendation. That in fact the vaccine is recommended, it's necessary, parents know enough to accept it, and they understand that the fact that their child is not sexually active means it's a great time to give the vaccine, where there'll be the maximal protection, since the child wouldn't have been exposed to any of the types that the vaccine prevents. When we ask providers, and this was again from a survey done a few years ago. This was by Melissa Gilkey and her colleagues, who surveyed providers and asked about how strongly they endorse certain vaccines given to adolescents. The providers acknowledged at that time that their endorsement of HPV vaccine, that the number of them that strongly endorsed the HPV vaccine was lower than it was for the other vaccines recommended for adolescents at 11 to 12. But when those same providers were asked to estimate how parents felt about it, there was a much bigger gap between the provider's perception of parental enthusiasm about the vaccine for HPV vaccine than there were for the tetanus and diphtheria acellular pertussis vaccine and meningococcal conjugate vaccine, the other two vaccines that are routinely recommended at 11 to 12. So providers themselves had their own concerns, but they believed the parents had much larger concerns than they did. And in contrast to that, when the parents themselves were asked, there actually was not that gap in perception. This is from a study done by Mary Healy and others in Houston, where both parents and providers were interviewed about a number of different vaccines, and the provider trend, or the provider's estimate of the parents' beliefs about the vaccine, shown in red, shows again that there was less enthusiasm the providers thought the parents had about HPV vaccine, but when the parents themselves were asked, at least in this survey, there was strong support by the parents, really regardless of the type of vaccine that was being asked about. So there is evidence that providers do tend to underestimate parental interest in and acceptance of HPV vaccine. So some kids start the series but don't finish it, and why is that? This is another paper by Rebecca Perkins, based on work that was done a few years ago about why adolescents don't finish the HPV vaccine series. And what she and her colleagues reported was, from talking to parents of kids who'd started the series but not completed it, that the most common reason was that they expected the clinic to remind them. While when the providers were asked about these same kids in terms of why they hadn't finished the series, they reported that they expected the parent to schedule an appointment. So that tells us a lot right there, that there's a big gap in terms of where the responsibility lies for completing the series. So what can we do about it? Well, there's a number of things that healthcare providers can do to improve HPV vaccine coverage in their practices. And probably the single most important one is that effective recommendation for HPV vaccination as cancer prevention for every 11 or 12-year-old patient that's seen. And here's what that recommendation looks like. Again, just to re-emphasize the point that was made earlier, it's linked to the child's age. It's because the child is 11 or 12 that these vaccines are being recommended now, because that's the routine age. That the vaccines are due today, so there's urgency about it. It's not something to discuss and come back to later. And it's protect from serious diseases like meningitis, HPV cancers, and pertussis that are serious conditions that are worth preventing, and HPV is no different from these other conditions. It's not something that has to be separated out and talked about in a different way, and we don't need to get into a big discussion about modes of transmission. It's not that parents might have questions about that. They might want information, and certainly providers should answer parents' questions, but there's no need to answer questions that haven't been asked and provide a lot of information in a different way than we talk about other vaccines. Providers may think they're being helpful in addressing concerns that parents have, but in fact the parent didn't have that concern. What they hear is that there's something different about this, and different is probably not good. So we recommend talking about HPV vaccine exactly the same way we talk about other recommended vaccines. And then there's other things that practices can do. Use your electronic health record or your immunization information system to look at coverage in your practice, and if you can do it at the provider level. In multi-provider practices, there probably will be some variation across providers in the practice, and there may be a way for the providers who are more successful at getting HPV vaccine high to assist in developing an office-wide strategy where other providers can be as successful as they are. And as was mentioned before, it's important to really engage the entire practice. The provider may be doing everything exactly right, but there could be others in the practice who aren't supporting HPV vaccine as cancer prevention, and that can be undermining all the good work that the providers are doing. And then finally, implement system strategies to improve HPV vaccine coverage, so that so that our computers are helping us, our electronic health record is helping us, our workflow in the office is helping us, that we've organized so that we really can be successful. And these are the system strategies we're talking about, things like standing orders for HPV vaccination beginning at 11 to 12, reminder recall, so that if families haven't come in yet, to give them that reminder to come in, or to remind them to come in to complete the series. Making sure you know about the patients who are on the clinic list to be seen that day, who's due for a dose of HPV vaccine or other recommended vaccines, and make sure that there's a prompt so that that gets brought out, it gets offered, it gets recommended, and hopefully it gets given. Scheduling a return visit for the next dose before the patient leaves the office, so you don't have that dilemma between I thought they would remind me and I thought they would remember. And then, of course, record keeping where each dose is documented in the electronic health record or the child's paper medical record and the state's immunization information system. So do these strategies work? Well, yes, they do. And there's a really wonderful published report from Denver Health, which is a network of federally qualified health centers in the Denver area that has a number of clinics as well as some school-based clinics. And they undertook a quality improvement project a few years ago to improve HPV vaccine coverage among their patients. And these are the strategies that they adopted. These are very similar to the things that I've just been talking about. Making sure that you know who's due for doses, checking to see who's on the schedule, needs vaccines at that visit, standing orders, making the recommendation for the 3 recommended vaccines as a bundle, monitoring provider level coverage and providing those coverage rates back to providers. And then they also did vaccination in their school-based clinics. And with those strategies, they were incredibly successful at achieving high coverage with 1 dose. Now, their complete series coverage was lower than this, but you can see with implementation of these strategies, they achieved very high coverage for both boys and girls for starting the series. And this is really, I think this is really very good evidence that these are effective strategies. So with those together, we can achieve high coverage, and we can protect young people from cancers, which is what we're really trying to do here. So thanks for your attention.
Wonderful. Thank you so much. All right, we do have a few minutes for some questions. We've received a number of questions via the Q&A portal. So I will, as the moderator, I'll take a couple and also ask our other speakers to respond to some of them. What you're seeing, just briefly before we go into the questions, this slide actually answers one of the questions. This shows, and we'll leave this up here for the whole Q&A. This is shows what the other topics are that are going to be covered this week. And someone had actually, the first question we got actually was exactly that. What are the topics for the other webinars this week? So you can see the various topics happening this week. Tomorrow will be a global perspective. Then there'll be another talk around non-GYN diseases, a little bit deeper dive into the non-cervical, non-vulvar, and vaginal cancers. So that I think will be very, very helpful. Friday will then focus again on back to cervical cancer and talk about the past and the present and hopefully the future of what we'll see hopefully with the talks that we heard today around increasing vaccine coverage and what we can hopefully expect to see around decreasing the rates around the world. And then Monday will be an exciting discussion around HPV and cervical cancer champions and how to join in this effort. All right, so we've answered the first question. There was an interesting question about whether the other HPV viruses, the ones that are not included in the vaccines, whether the prevalence of those other viruses has changed since individuals started to get vaccinated with Gardasil and Cervarix around the world. Personally, I'm not aware that there's been any large-scale enough epidemiologic studies yet done to be able to show changes in prevalence. Typically, those changes in prevalence are likely to happen over many years. But if either of the other speakers are aware of any studies, Australia would probably be the place that would be able to look at this question, since they've for a long time had some of the highest vaccination rates in the world. Teresa or Melinda, are you aware of any?
No, I haven't seen whether there's any change in the prevalence of the other oncogenic HPV viruses.
Thanks. Melinda?
Same. As far as I know,
Yeah.
the monitoring that's been done so far has not indicated any change.
Yeah, and this is, I do remember while working on the Gardasil vaccine, there was that concern, and that question was raised many times. So I'm sure that there are studies being done, and this is a very, very important question to ask. There are a couple questions that are kind of related, so I'll take those sort of together. There was one question about whether Gardasil 9 is as effective in preventing HPV or other diseases in the older population as compared to the younger population. And then there was also a question about Gardasil 9, and the person asking the question had not realized that actually types 6 and 11 were also in that vaccine, that it was also a genital warts vaccine, basically, and asking whether there are studies that show the efficacy for that. So for the first question around whether Gardasil is as effective in the older population, Gardasil 9 is still highly, highly effective in the older population, and the older population meaning women aged 27 to 45. It is slightly less effective, though, and it's believed the reason for that mainly is that as folks get older, our immune systems just aren't as strong. So our responses to getting vaccines of any type actually maybe are less strong. So it's really mainly for that reason. Gardasil 9 is still approximately close to 90% effective in this older population against cervical dysplasia. And remember, the vaccines did not show prevention of cancer, right? The vaccines showed prevention of the precancerous changes. But studies looked at vulvar precancerous changes, vaginal and cervical, and again showed close to 90%. I believe it was 88-ish% effectiveness in the older range population. The actual effectiveness preventing disease in men was not shown in that age group, but because the diseases are so similar in terms of how the virus causes disease, effectiveness in men in that age group was inferred or sort of assumed from the efficacy data in women, and that is how they approved it in men. Men were also shown to have similar immune responses to the vaccine, so that also supported making the vaccine available in older age men as well as women. In terms of the Gardasil 9 protecting against genital warts, disease caused by types 6 and 11, the vaccine is highly effective, and the studies that were done for Gardasil initially showed about 99% effectiveness in females in protecting against genital warts and about 90% effectiveness in males. So again, highly, highly effective. And those papers are published out there. So, and also can be found in the package insert with a label. You can find those efficacy numbers. All right. There is a question about Gardasil 9 and whether it's covered yet in that older population, and I do not know the answer to that. Teresa had agreed to take that question.
So yes, it is generally covered. I still recommend though that patients call their insurance company, because even if it's covered, depending on your plan, if you have a high deductible plan, you may still have to pay out of pocket for the cost of the vaccine up until you reach your high deductible. So you may want to know up front how much you're going to be paying out of pocket, even though it's technically covered. Most of the immunizations are covered without a copay. For the older patient, you might want to check that first. But in general, they are technically a covered entity and considered part of prevention.
Thank you so much. There's a question, there's a bunch more questions that have come out since the end of the talk. So one more for you, Teresa. This is a great question around providers not having their schedules up in 6 months out and making that second shot difficult to schedule. Do you have any sort of strategies?
Absolutely. A provider needs to be the one giving the shot. Usually what we do is we set it up as a nurse visit. So you get your first shot. For those over the age of 14, you get your first shot, and then you get your second shot about a month or so later, and then your third shot if you're over the age of 14, 6 months later. So for those follow-up shots, you don't have to see the physician or the provider. It can be just done purely as a nurse visit to come in to get their follow-up shots. We like to do, especially those younger than 14, it's great to do your hepatitis A vaccine along with your HPV shot, because then you do one shot now and another shot in 6 months, and you can give them both at the same time. So don't use up the physician's time for just doing those shots, those follow-up shots. For the initial one, yes, but for the follow-up ones, they can be done as a nurse visit.
Thank you so much. Another question related to sort of more generally our thoughts on involving other health-related professionals in vaccine recommendations. Is there evidence that getting the same message from multiple sources is helpful? And I'll give that one to you, Teresa and Melinda.
Oh, sure. We'd like as many people as possible getting involved. Now, the hassle is that outside of the medical community, there are not a lot of vaccines being given in other offices. So, for example, your dental professionals would not necessarily be giving the shots, but that would be an idea to think about and consider. We need as many people as possible talking about it and bringing it up. And so having the dental professions be involved with encouraging their patients to get the vaccines would be incredible. Another great way of utilizing people is through the pharmacists. I mean, the pharmacists are now giving a number of vaccines at the pharmacy rather than in the office. The key thing is to get it done. So as many people as we can possibly get involved or have access to be able to give the vaccines, the better.
Yeah, this is just to build on that. The American Dental Association has been very interested in this topic, being understandably very concerned about the increase in the oropharyngeal cancers that are now being seen due to HPV. And although there's a lot of things that have to be done to be a vaccinator, so I don't know that it's realistic to think about dental offices actually giving vaccines. What a great recommendation to be able to make to parents. Often dentists see the entire family.
Yeah.
They'll know how old the kids are, and they can provide that recommendation from their perspective as a trusted dental healthcare professional, that this is really a great opportunity for prevention, and how concerned they are about the increasing incidence of the HPV-related oropharyngeal cancers, and that now there's an opportunity to prevent them. So I do think that the engagement of dentists and other dental professionals in this discussion is could potentially be a very helpful.
Thank you so much for that. And on the topic of oropharyngeal cancer, someone asked a question about advocacy. Her husband was actually diagnosed with HPV-related base of tongue cancer, and the side effects for him are really, part of his everyday life, as she says. What about advocacy on the part of patients?
Well, we know we have to increase vaccine rates. We want to definitely make lives better for people. As a physician, my role is to prevent disease. It's so much easier to prevent something than to treat it after the fact. And I would encourage the attendee who brought forth that question, use your husband, use your family. You know, when they see a person, when they hear a story, it's much more impactful. One of my cousins had a neck carcinoma, and after he learned that it was HPV related, he has been the biggest advocate for the HPV vaccine among all of his friends and family.
Thank you so much for that. That's very, very powerful. I think we can take one last question live here, and I think it's a very important question. I've had to sort of select out of all the amazing questions that we have received, so I'm really sorry if we don't get to your question live here, but I do think this one is extremely important, which is for Teresa and Melinda. How do you talk about safety of the vaccine when you're discussing it with patients and their families?
Well, there's a very simple way. I like you, I like your kid, I love my children. I would never do anything that would put them at harm. And if I'm willing to have my own children be vaccinated, I think that's probably one of the strongest recommendations that I have for the vaccine. Now, if you look at all the specific data and if you look at the scientific data, and I would certainly have folks go to the CDC website to read about it, there are certainly going to be no question that it's a safe and efficacious vaccine. But I do use my own family when I bring up the how strongly I feel about the safety of this. Melinda?
Yes, I think that's an excellent way to address the kind of high-level question or concern that comes about that. And there are detailed answers to specific vaccine safety concerns that CDC has on their HPV vaccine safety webpage. I guess the other point that I'd make is that sometimes the concern about safety is because of the impression that somehow this is a new vaccine, and since it's new, there must not be that much experience with it. Well, we've had licensed HPV vaccines in the United States for more than 10 years now. Globally, hundreds of millions of doses have been given, and much of this vaccine has been in countries with really excellent vaccine safety monitoring capability. So our vaccine safety people here at CDC have very closely looked at the U.S. experience along with their colleagues at FDA. And one thing that we did observe early on was an increased risk of fainting with vaccination. It's not HPV vaccine in particular, but it's any sort of needle involving medical procedure done for kids this age. So we actually see it with all of the vaccines recommended for young preteens or young teens. And that can be really pretty serious. There can be, if someone faints from a standing position and hits their head, they could be very seriously injured. And so we've actually changed our vaccine administration recommendations to recommend that people stay seated for at least 15 minutes after receipt of vaccine in order to provide that protection from passing out from an upright position. And that's in response to adverse events that were reported following initial recommendations for HPV vaccine years ago. So this is something that we look for, and when we find things, we make recommendations about what to do about it. And we have a very robust safety experience now with HPV vaccine that demonstrates that this is really a very safe and well-tolerated vaccine.
Thank you so much. And on that note, we've reached our time limit. So this all brings us to the end of today's webinar. Thank you so much to Melinda and to Teresa for the fabulous talks and in particular for really excellent answers to the questions. Thank you to the audience for your great interest. Like I said, we received a lot of really, really great questions, and apologies we couldn't get to all of them right here on the phone, but we'll do our best to get answers to you. And you can visit Us versus HPV for details on how to get the handouts and recordings. And our colleagues will be here same time tomorrow. And the topic is going to be HPV and cervical cancer, a global success. So thank you so much for your participation, and we look forward to you joining us in our HPV awareness campaign.